Good morning to Prof. Datin, Dr. Marina, professors, doctors, and also, of course, students. Welcome to today's Clinical Pathological Conference. My name is Philip. I'll be your MC for today. On today's CPC, our presenters or panelists are Dr. Mohamed Shafiq Azhar from Department of Ortopedics and Traumatology, together with Dr. Afif Abdul Latiff, also from Department of Ortopedics and Traumatology, and also Prof. Dr. Suraya Binti Aziz, our consultant radiologist from the Department of Radiology, and finally Dr. Tang Lik Sian from the Department of Pathology. Before we start for today's presentation, I would like to invite Dr. Hifzan for the prayers recitation this morning.
Assalamualaikum. We'll begin our morning prayer recitation with Ummul Furqan Al-Fatiha. Amin, 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 ya Rabbal Alamin. A'udzu billahi minasyaitonir rajim. Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alamin. Wassalatu wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi wa sahbihi ajma'in. Rabbana ighfir lana wa li ikhwanina allazina sabaquna bil iman wa la taj'al fi qulubina ghillan lil ladzina amanu innaka ra'ufur rahim. Ya Allah, Ya Rahman, Ya Rahim, pada pagi ini kami berhimpun menzahirkan kesyukuran kepadamu, Ya Allah. Kami menadah tangan berdoa dan memohon kepadamu, Engkau berkatilah dan permudahkan perjalanan persidangan yang kami adakan pada pagi ini. Allah marzuqna fahman nabiyyin wa hifzal mursalin wa ilhamal malaikatul muqarrabin. Ya Allah, kurniakanlah kepada kami kefahaman para nabi, hafalan para rasul dan ilham para malaikat yang dekat denganmu. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawlin. Ya Allah, Ya Rahman, Ya Rahim, bukakanlah pintu hati kami, lapangkanlah dada kami, kuatkanlah ingatan dan hafalan kami, lancarkanlah lisan dan penulisan kami. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina azaban nar. Subhana rabbika rabbil izzati amma yasifun wa salamun alal mursalin walhamdulillahi rabbil alamin.
Thank you, Dr. Hifzan. Next, I would like to invite Dr. Shafiq on the first part of the presentation of today's CPC.
Assalamualaikum and a very good morning to professors, specialists and dear colleague. My name is Mohamed Shafiq bin Azhar. Today I will be presenting first part of the lectures. I will guide you guys on how I'm going to reach to the final diagnosis step by step. So, beginning with the history. Patient is a 25 years old male with no known medical illness, presented with 3-month history of right knee pain, which is sudden onset and dull aching in nature, which gives us an idea that it is a progressive pathological process. The pain is non-radiating, meaning it is localized to the right knee and it is not coming from the spine. Pain score was initially 2/10, aggravated by prolonged standing and walking. However, the pain progressively worsened for the past 1 month, escalating the pain score up to 8/10. And the pain also made him require walking aid for ambulation. However, he denies any night pain, which pointing towards a more benign pathological looking pathology. 2 months into the history, he developed right knee swelling, which was gradually increasing in size, and the swelling limits his right knee range of motion and affected his daily activities. He denies any trauma or fall, which making post-traumatic or sports-related injury less likely. He denies any prolonged fever or discharge from the lesion, which commonly associated with infective causes like osteomyelitis or septic arthritis. There was no constitutional symptom such as loss of weight or loss of appetite, which can be seen in malignancy. And finally, there was no other joint pain involvement to suggest for any inflammatory or rheumatological condition. So moving on to systemic symptom review, it was unremarkable. No respiratory, cardiovascular, gastrointestinal or neurological symptoms. So no past medical or surgical history. Patient does not have any family history of malignancy before this. He is an engineering student at UTEM. He is a non-smoker and no history of previous alcohol intake. So based on the history provided, there are 2 differential diagnoses that we can include. Number one, tumor. And number two is infection. Tumor was suspected in this case because pain occurred first, followed by the swelling, which pointing towards a bony in origin pathology. Meanwhile, infection is also considered, even though that there is no history of prolonged fever or discharge coming from the lesion, because infection like TB can mimic tumor-like presentation. So we've completed the history part. Next step would be the clinical examination, which will give us more information about the problem. On general examination, patient is not cachexic looking, walks with antalgic gait, and need crutches for ambulation. On inspection, there is a single swelling over anteromedial aspect of the proximal right leg, measuring 4 times 4 centimeter in size and extending posteriorly. Actually, this is an important point, and I will explain to you guys later on. The overlying skin is normal, no dilated vein or ulceration, which can be positive in features of malignancy, no erythematous or discharge that can indicate any sign of infection. So moving on to palpation, there is tenderness over anteromedial aspect of right knee. It is not warm to touch. The mass is hard in consistency on palpation. It is lobulated surfaces and ill-defined margin. The mass is large in size, causing the overlying skin to be not pinchable, and upon muscle contraction, it became less prominent and less mobile, indicating that it is deeper in origin. There's no knee effusion palpated as well. So for the range of motion, it is from 5 degree to 120 degree. Note that there is 5 degree mild extension lag that can be due to pain or mechanical block. So remember that I mentioned just now that the mass extending to the posterior aspect of the knee. Thus, it is important for... Okay. Yeah.
So we're looking at the knee now. We're going to talk about neurovascular assessment. What neurovascular assessment is it supposed to check? Now let's see. Where's Divan? Do you need this? What neurovascular structure is around that region before he goes on?
That's blood artery vessels.
Yeah, neurovascular Desmond. Oh, okay, very good. Yeah.
Popliteal artery. So we should look for palpation of the popliteal artery to make sure there's any compromisation of the vascular part. And for neuro part, maybe we can look for any compression of the nerve around the knee. Yes, Prof.
Which nerve?
Popliteal nerve.
It's okay. Sit down. I don't know what you learned when you were here, but never mind. Carry on.
Yeah, actually you got half of it correct. So yes, as I mentioned before, the mass is in close proximity to some of the vital structures. So what are the vital structures located in this region? Actually, we have a popliteal artery at the back together with the popliteal vein and tibial nerve at the popliteal fossa. And over the lateral aspect of the popliteal fossa, we have the common fibular nerve. Later on, Dr. Afif will present on detail regarding the complication of this problem if, let's say, it is compressed. So any compression to this structure as well, such as the nerve or the artery, will result in impairment to the power, sensation, or circulation. But in this case, a neurovascular assessment was normal. So for any suspected tumor case, systemic examination are crucial to exclude any malignant potential. Especially lung mets, because it is commonest site for bone tumor to metastasize to the lung. And in this case, it is unremarkable. No regional lymph nodes palpable. Chest auscultation was clear. CVS was duodenum normal, and there was no organomegaly. Now we're going closer to the diagnosis based on the clinical examination. Bone tumor.
Okay, stop again.
Oh, sorry, bro.
Challenging. I rasa stress pagi ni. Okay, so now we go for the next one. Let's get some answer. We need a differential diagnosis. You've already got the differential diagnosis earlier on. So from based on that, have you narrowed it down? Well, I don't know the names of the medical student. Who's going to volunteer? Perhaps, Prof, you know. Medical student, volunteer before I point to you. Okay, so that girl there, okay, I'm going to come up actually. It's just easier like that, isn't it? Okay. I'm very upset now because you're making go up these stairs. I'm rolled like that. Okay.
Good morning.
Morning.
Prof.
So we've had a few differential diagnoses just now. Did you remember? What was it before this, after history?
Tumor and infection,
Very good.
TB.
So have you narrowed it down, do you think? Is it after clinical examination? What do you think? What is the likely diagnosis based on the clinical? So after history, you think it might be tumor and it might be infection. So what is the point of doing clinical examination? Is so that you can try to have more information. After Dr. Shafiq has said that, have you come any closer? Anything going through your head at the moment? Okay, no response.
I think
Sorry, carry on.
I think it more
Sorry, are
pointing
you third year, fourth year, fifth year? That's
fifth
actually.
year, sorry.
Also, you should know. So it's not third year then. So you've done orthopedic posting then.
Yeah.
You're never gonna do it again, ever.
Yes. Okay, so I think it pointing towards tumor, and it's more like a benign origin.
Okay. What do you
Based
say,
on-
benign?
Because based on the physical examination, there is no first is the progression. It takes 3 months,
Right. That's to show malignant.
and then there is no aggressive looking of the tumor, and
Okay.
there is no sign of metastasis
Okay. That's it. Metastasis where? Actually, that's quite
to
good.
the lung.
Very good. Very good. Yes. Okay. That's right. Okay. So she thinks it's. Did you hear that? She's very
Yes,
soft-spoken.
yes,
Is she?
yes.
Right.
I
Okay.
can hear
Very
that, Prof.
good. Moving on. Thank you, Dr. Shafiq.
Yeah, thank you so much for the feedback. Actually, yes, you're getting most of the points correct.
Oh, sorry. Carry on.
At this point of time, like the student mentioned just now, bone tumor is a more likely diagnosis, as
But nobody
from the
wants to
clinical
do that.
examination, the mass is fixed, is hard in its consistency, making a bone tumor is a more likely diagnosis. So bone tumor in 25-year-old patient can be further subdivided into benign or malignant. For benign bone tumor, it has to be something aggressive, such as giant cell tumor or aneurysmal bone cyst. And for malignant bone tumor, the example would be like osteosarcoma or Ewing sarcoma. Mind you that during this age group, it is not common to get aneurysmal bone cyst or Ewing sarcoma. So we've completed the history, perform a detailed clinical examination. Now we need further investigation to guide us to get through the diagnosis. So blood investigation were within normal range. Infective parameters were not raised, such as white cell count, ESR, and CRP, pointing towards making that infection is less likely. So next step will be radiological investigation. This is an important step, as this will provide us a clue regarding the location, the extent, or the nature of the pathology. With that, I would like to welcome Prof. Suraya to discuss regarding the radiological investigation.
Okay, thank you, Dr. Shafiq. All right. Okay, right. So, is that all right? Okay, so for radiological investigation, to start with, you normally would do the basic investigation, which is the plain X-ray. Okay, so for this patient, we have the right knee radiograph in AP and lateral projection. And if you note that the patient epiphysis is closed, meaning that the patient is already skeletally matured. Okay, then the marked thing that you can see in this radiograph would be the lytic lesion. So when you see a lytic lesion, you have to see where the location is in regards to the long bone. So you can see that it occupies the meta-epiphysis location. Okay, and when you look at abnormality, you would want to investigate how the margin is, and that is what we call the zone of transition, where you can see the demarcation between the abnormality and the normal bone. So if you can make out the border, which is like this, it is quite well defined. So it is pointing towards a benign lesion. Okay, I will show you later the differentiation between benign and malignant bone lesion. Okay, so next, you would want to know whether there is any cortical involvement. So if you look at the lateral aspect, the lateral view, you can see posteriorly the cortex is very thin out, and there is a possibility of a cortical breach. Okay, so that is pointing towards an aggressive nature to a certain extent. Okay, so then we look for any presence of periosteal reaction. Okay, so periosteal reaction meaning that there is irritation to the periosteum by any process, like an inflammatory process or infective process. And in this patient, there is no periosteal reaction seen. Okay. The next thing, you would want to know if there is any soft tissue component. Oops. Okay. The soft tissue component in this patient is absent. The next thing, you also can see that this lytic lesion is actually subarticular in location. That means it abuts the articular margin there. And if you look closely, within this lesion, there is this thin septation within. So when you have all these features, it is pointing towards a benign lesion, and you would want to consider at least two differential diagnoses. Although there is one aggressive factor that you would want to consider. Okay? Right. So if you look at this diagram, you want to concentrate on the epimetaphyseal region where the abnormality was seen in this patient. Okay, so for any lytic lesion at that region, and if you can see here at this diagram, you just have these two, GCT, which is the giant cell tumor, or the other one is aneurysmal bone cyst. So you have to differentiate between the two. And for the other one here, chondroblastoma, the look is different and the age doesn't fit in this patient. Okay, so we can remove that from our differential. So these two differential diagnoses. Okay, right. So at this point of time, I think if you want to consider between the two, the classic features that you see in giant cell tumor is occurring in a closed epiphysis patient. It is more at the epiphyseal location and abuts the articular surface in 98 to 99%. It is also eccentric, but in this case, it is large, so it is a bit difficult to meet that factor. Okay, and the lesion is well defined, and there is no sclerotic margin. This is what I call the narrow zone of transition. You can see any pathological fracture if it's present, but in this patient, we can't ascertain that. I mean, it is thinned out at the posterior aspect of the cortex. No matrix calcification or mineralization. Okay, so when you consider all that, we have to check again the features that favors a benign bone lesion as compared to a malignant bone lesion. So, okay, now if you can see under benign, it has a well-defined margin as compared to ill-defined margin in malignant lesion. So ours meets this. It has a narrow zone of transition as compared to a wide zone of transition. This would be a ill-defined margin, okay? Ours is a well-defined margin, so it is still under benign. Is there any cortical breach? Ours didn't show obvious cortical breach, but in malignant lesion, there would be cortical breach or even bone destruction in an aggressive lesion, okay? And if there is any periosteal reaction, for benign lesion, if it's present, it looks solid. So that would concur with a benign lesion. And periosteal reaction in an aggressive lesion, it will show different types of aggressive periosteal reaction, which is not present in this patient. Okay? Right. Just to complete, apart from being the X-ray, we would want to do the MRI of the left leg. And this was seen on the coronal T2 weighted image. This is a T1 weighted image, and this one when we applied contrast. Okay, so what we can see in this lesion, which occupies at the proximal tibia, is predominantly intense lesion on T2, which is also intense on T1, and on T2 there are areas which show hyperintense. So this is the high signal intensity or the white areas. So this means that there are fluid or cystic areas. Okay, so when we apply contrast, there is most of the mass enhances homogeneously, except a rim enhancing. It does not enhance at the cystic lesion. Okay, so this is how it looks like. So in that. On the axial, actually we did twice the MRI. The lesion was getting larger, and the neurovascular bundle, if you can make it there, because the lesion is occupying most of the leg at that time, it has been displaced, and there was no evidence of thrombosis of the popliteal veins. Okay, and the posterior compartment muscle also does not show any enhancement, thus does not suggesting any involvement. Okay, so finally, the cystic lesions, how does it compare with ABC, the aneurysmal bone cyst? So in aneurysmal bone cyst, it is quite characteristic for you to appreciate for fluid level to be present, which is not present in this patient. So thus, it makes that GCT more likely in this patient. Okay. So, yep, most likely diagnosis of the MRI is GCT, and as I said, unlikely to be ABC as there is absence of the fluid level. Thank you. Okay, so I can call.
Sekejap, Suraya, there's a question here. Prof. Suraya, thank you for the very nice description. I think the medical student would benefit. You outline one by one. But I want to know, from the investigation, from the hyperintensity on T2, and then you inject contrast, how can you differentiate these findings between a tumor and a vascular lesion?
Oh,
yeah.
Okay. So if it's a vascular lesion, so that means the enhancement will be more avid, and it would follow the same enhancement as in the blood vessels. So here, I think we can't appreciate much because the blood vessel is at the back. So it should be as hyper intense, as high signal as it is here, which is not seen in this mass. So this is more of a soft tissue rather than a vascular mass. Okay.
Perhaps I can add on to that to help her out, because apart from this, vascular lesion, they've got some characters as well. They've got things like spontaneous lesion, and they don't have this this is like a blob. It's like very well defined. Not well defined, you can see there's a lesion, whereas vascular, it doesn't have this sort of nice, well defined. So you can have that kind of thing.
So it's like the character itself is different. And you can see if it's a venous thing, you can see evidence of fibrillith as well. So it's actually quite difficult sometimes to see with MRI, and we have to supplement it with our ultrasound as well. So that's how we tend to differentiate between a vascular lesion and a solid tumor lesion.
Thank you. Thank you, Dr. Hazla.
Okay, thank you, Prof. Soraya, for the detailed explanation regarding the radiological finding. So as we know, radiological imaging is part of the staging system. So before we proceed, what is staging? Staging is a protocol to determine the type and extent of the lesion by doing clinical evaluation, radio imaging, and histopathological evaluation. So staging can be further divided into local staging and systemic staging. And just now we already mentioned the X-ray and MRI are part of the local staging, and CT scan is part of the systemic staging. And for this case, CT thorax already been done and shows no metastasis. So we've completed the history. We perform a detailed clinical examination and perform relevant investigation for this case. Final step would be biopsy. So what is biopsy? Is a procedure to obtain a tissue sample from the body for histopathological evaluation. In this case, biopsy is performed to confirm suspected bone tumor, to exclude infection, and to determine the biological behavior of the lesion, which will directly guide our management later on. And mind you that CNS will not perform as the infection was considered a less likely diagnosis in this case. So I would like to invite Dr. Tang to explain regarding the HPE finding of the patient.
Good morning to professors, lecturers, doctors, and our fellow colleagues, and also medical students as well. So I'm Tang here, so I'll be presenting on the pathology part for this bone tumor. So we received a bone tumor biopsy on the 22nd of August this year. Microscopically, it's labeled as bone. We received multiple pieces of brownish tissue measuring about 30 millimeters in aggregate diameter, and we entirely submit in 2 blocks. So this is a low power view of the tissue fragments. As you can see, the blue parts are the tissue and the red parts are the blood. And we can see also, generally, they are same throughout the whole tissue fragments. They are also same color, same number of cells. So let's zoom into one of the tissue fragments. Okay, so this is one of the tissue fragments. It's not the best picture quality. Later on, we'll have a better quality pictures. But if you see this under a microscope, or even here, we can see there are actually a lot of big cells. You can follow my cursors. Here, you can see there are abundance of big giant cells. All right. So these are called giant cells, or osteoclast-like giant cells. And at the background, you can see they are actually very cellular. All right, the whole tissue are cells, so they are highly cellular tissue. So let us go slightly more higher power view. Again, we can see there are abundant of these rectangular boxes. All these are the giant cells. All right. And then at the background, there are a lot of cells. So I'll move on to another much higher power so that we can see better what are the cytology of these cells. All right. So this is the highest power we can go. Okay, so let's go on to this rectangle box here. We can see they are multi-nucleated. What it means there are many nuclei. And then it share one cytoplasm. We can see this distinct border of this red color thing. That's called the cytoplasm. So this cytoplasm is red in color. So it's in histology, we call it eosinophilic cytoplasm. So we have a distinct border of eosinophilic cytoplasm and many nuclei inside. So we call this a multi-nucleated giant cells. Or in this case, it's called as osteoclast-like giant cells. So we have a lot of them here. 1, 2, 3, and many more. Therefore, the name called giant cell tumor. However, this is not the neoplastic cells. This is not the cell of interest. The tumor cells are actually the background cells lie behind at the background. So these are called the neoplastic cells. So these cells, they are usually monomorphic, or what we call monotonous, uniformly. You can see throughout the tissue, they are round only, round. But they also can be spindle and oval as well, but commonly are round. So if you go into the cytology, they are not only that they are round, And then the nucleus itself, you can see they are slightly clearing. In some area, they are slightly clearing. That are called open chromatin. And within the nucleus, you can see some prominent 1 or 2 dots. That are nucleoli. So round tumor, a round nuclei with open chromatin and 1 or 2 small prominent nucleoli. And then you can see at the side, the red color one are the cytoplasm. So, and then they are not distinct like the giant cell. You can see here, you can see a distinct border. So in here, they are indistinct border. So in summary, they are round nuclei, open chromatin, 1 or 2 small nucleoli, and indistinct eosinophilic cytoplasm. Okay. So these are the typical features of giant cell tumor. So let me go through about 2 minutes on a slight introduction to giant cell tumor.
Dr. Tang, before we go on, thank you. So that's quite comprehensive. So giant cell, you see a lot of giant cell there. I'm right in thinking there's a lot of pathology with a giant cell, right?
Yes, correct.
Perhaps we can ask the medical student other pathology where you have giant cell in the histopathology. Neville, give her, yep. So apart from giant cell tumor, what are the diseases that you know of that will have giant, multinucleated or cell? Okay, just give it to whoever on that side, perhaps. And then Dr. Tang can tell whether they're right or wrong.
How about like chondroblastoma?
Yes, that will be correct. So actually, giant cell itself is not a pathognomic findings for giant cell tumor. Giant cells actually is quite common to see in other bone tumors as well. And there are 3 important giant cell rich bone tumor. One of them will be giant cell tumor. Another one will be aneurysmal bone cyst. And the third one will be non-ossifying fibroma. And what the students have mentioned, chondroblastoma is another chondrogenic tumor or cartilage tumor that also has a lot of giant cells. So therefore, presence of giant cell itself is not pathognomic of giant cell tumor. So you have to remember that there are other differentials which also has giant cells as well. So this is just regarding on bone tumors and cartilage tumors. Of course, if in soft tissue, things like foreign body objects, foreign bodies also can elicit giant cells, and also TB. TB also can have giant cells. However, there are different types of giant cells. If later on you can have a read, there are different types of giant cells. In TB, they are more towards Langhans type giant cells. Instead of this, Langhans type will be like nicely lying at the periphery, forming like a horseshoe shape. But again, it's not specific to TB. It's more frequently occurs in TB. So it's not like you see Langhans, all these TB. No. So it's more frequently to TB, but it can also be other things as well. Okay. But in this case, this is not Langhans type. This is just many histiocytes fused together and form a giant cells. But because in the background there is a tumor, so this is osteoclast-like giant cell tumor. Osteoclast-like giant cells. Okay. All right. Can I proceed, Prof? All right. So before, I think our orthopedic colleague will later on further expand on this, but I'll go through a slight introduction to giant cell tumor. So as what our colleague has mentioned, is a very locally aggressive neoplasm, and they compose of neoplastic mononuclear stromal cells. Mononuclear means cells with single nuclear. As what I've shown you what the background stromal cells is. Single nuclear cells and with monotonous appearance. They are all same size, same shape. Okay, and then they mix with a lot of osteoclast-like giant cells. They typically affect the ends of long bones in a mature skeleton, as in this case at the proximal tibia. And pathogenesis-wise, about 95% of them harbor pathogenic H3-3A gene mutations. And lucky for us, about 90% of them have this H3.3P GLY34TRP mutation. So why is it lucky? Later I'll tell you. So macroscopically, if you receive a resected specimen, they are usually well defined as seen in the radiology. And then the cortex surrounding it usually will thin and can be completely destroyed, again as seen in the radiology as well. So if we can see the whole tumor, usually they are soft, very friable, brownish in color, and sometimes there will be have reddish areas indicating hemorrhage and yellowish areas indicating necrosis. Okay, so histopathology-wise, as what I've mentioned before, this is a highly cellular. You see many cells in the tissue fragments, and then they have a lot of osteoclast-like giant cells, and between them or at the background there are the mononuclear cells. So they usually are round, sometimes can be oval, and occasionally can be spindled. And the cytoplasm are red in color and ill-defined. And if you see a nucleus, they usually sometimes are clearing a bit. That is called open chromatin, and it can contain 1 or 2 small black dots that is called nucleoli. And of course, we have necrosis, hemorrhage, aneurysmal change, and foamy macrophages. And the cortical bone are usually eroded. And now we come to this. So not many places have this molecular analysis. So we have this immunohistochemistry study, G34W, which is a reliable surrogate marker, but if you don't have the molecular analysis, we can use these stains to help us to diagnose giant cell tumor. So this is the typical picture taken from WHO tumor online. So you can see, once look, giant cells everywhere, but that are not the tumor cells. The tumor cells at the background, very cellular, single nuclear cells. All right, that is all from me. Thank you very much.
Okay, Assalamualaikum and a very good morning. I bid to professors, lecturers, colleagues and also students. So I'll continue with our conference this morning. I'm Afif from Orthopedics department. So thank you to Dr. Tang with the very insightful explanation. So usually when we get the report from the departments of pathology, at the end of the lengthy explanation, we will have a please correlate clinically. So now let's correlate it clinically. Okay, so from the history examination as well as the radiological findings, we can see by the age of the patient, okay, being the pain comes before the swelling, and from the radiological examination, there's lytic lesion over the epimetaphyseal region, as well as what the Tang said, the presence on histopathology, there's presence of giant cell with a background of mononuclear cells. So we can safely conclude that this patient is actually having a giant cell tumor of the right proximal tibia. All right. So, what are the management of how do we manage a giant cell tumor? It can be one of it is doing a curettage, and the other extent is doing a wide local resection, where wide local resection being removing part of the tumor with a cuff of normal tissue surrounding the tumor, and that is what we did to this patient. So we did a limb salvage surgery which comprises of wide local resection together with skeletal reconstruction and endoprosthesis. Now I'll bring everyone into the operation theatre and see what we have done to the patient. So for the first part, we go from the most superficial part, which is the skin. The important part of this step is when we are doing a skin incision is to remove the biopsy tract together. As you can see, the white arrow showing an island of skin and a small dot in the middle. That's the biopsy, the previous biopsy tract. If we don't remove the biopsy tract, we might leave some micro tumor cells to the patient, and this may cause a high risk of recurrence of the tumor. So after we incise the skin, we go deeper inside. Okay, so now our main objective is to remove the tumor. But as you can see here, there's a lot of soft tissue that is encapsulating the tumor, which is the proximal tibia. So we need to dissect the soft tissue from the tumor. So now we can see the above arrow, follow my cursor here. The above arrow, this one is the soleus muscle. This is the proximal part of the tibia. And this muscle over here is attached to the skin, which is the medial gastroc. Both of them are the posterior compartment muscles. Once we detach it, we go deeper inside, and more proximally, we can see a conjoint tendon, which is called the pes anserinus. Is the conjoint tendon of the hamstring muscles, which comprises of sartorius, gracilis, as well as semimembranosus. Then we detach it from the tibia. Now, come to the point.
where Dr. Shafiq and Prof. Suraya mentioned how close the proximity, as you can see here, is the tumor. And these are the popliteal vessels and so the tibial nerve just behind. And luckily for this patient, it was not involved. So after we look at the popliteal artery, we know that popliteal artery trifurcates into 3 other arteries, which are the anterior and posterior tibial artery as well as the peroneal artery. So once we have identified and protect these structures, we have completed the dissection over the medial side. Now let's go to the lateral side. So from the laterally, we can see that's the iliotibial band, which comes from the buttock area down to the Gerdy's tubercle at the proximal anterolateral part of the tibia. As well as distally here, you can see that's the tibialis anterior muscle, which attached to the proximal part of the tibia as well as the distal femur. So we detach this muscle. And finally, you have to identify this very vital structure, which is the common peroneal nerve. Because injury to this common peroneal nerve will result the patient to have foot drop post-operatively and will detrimentally affect the gait of the patient. After finishing the lateral side, now finally we go to the anterior aspect of the knee, where on the picture of the left-hand side, that's the patellar tendon, which is attached to the distal pole of the patella and attached to the tibial tuberosity. And on the right-hand side, you can see the capsule over the median and lateral aspect, as well as the collateral ligaments, and some intracapsular structures, which are the cruciate ligaments. Finally, we have finished our dissection, and now the next step will be determining the level of resection. So with the aid of MRI, we measure about 2 cm normal bone distal to the tumor, and then we take the measurement from the joint line down to the intended resection site, and we mirror it inside the OT using a ruler. Then once the osteotomy is done, this is how the tumor look like after we have taken out. So the important thing that we don't see the tumor as well as this biopsy tract over this island of skin that I mentioned just now. After resection, we can see there's a bone defect. So now there's no connection between the femur and also the tibia. So what we did was we need to fill up this space in order for the patient to have their function. So we did a skeletal reconstruction using endoprosthesis. Now we have an implant inside. The next step will be covering up the implant. So what we did was using a posterior flap, which is a medial gastroc, to cover the implant. And finally, we have managed to close the skin. Post-operatively, patient was allowed to fully weight bear. However, we must ensure that patient weight bear in full extension and only allowed for gradual range of motion after 2 weeks and full range of motion after 6 weeks. Why? Because we have reconstructed the extensor mechanism, and it's very important for us to protect this reconstruction. After patient was discharged, we have to do active surveillance. Number 1 is to detect local recurrence. As we know that GCT is an aggressive tumor and also have the tendency to metastasize to the lungs. Therefore, what we do is we will see the patient every 3 months for the first 2 years, and then 6 monthly for the 3rd to 5th year, and annually from there on. On each appointment, what we do is we repeat a radiograph of the pathological site as well as a chest radiograph to detect any metastasis. If anything that we see here that signs or shows toward recurrence, patient may need to undergo another surgery. Okay. Now, come to the part of our discussion this morning on our conference. So, on this CPC, we will discuss about limb salvage surgery in the treatment of giant cell tumor. So, giant cell tumor is a benign but aggressive tumor which occurs in skeletally mature patient, occurs around 20 to 40 years old, over the meta-epiphyseal region, as mentioned by Prof. Suraya, and the common bones that is affected by this lesion is around the knee, which is the distal femur and proximal tibia, but can occur over the distal radius and also sacrum. So it tallies well with our patient by the history and also the imaging. So Andy King has classified giant cell tumor as an aggressive bone tumor. So what does that mean? So it has a behavior of a progressive growth, invasive, and not limited by natural barriers. It can invade the cortex, go off the periosteum and into the soft tissue, as well as the tendency to metastasize. And another grading system by Kapanachi, this is a very specific for GCT and is important for us surgeons as it will aid in our management later on. So it classifies based on the involvement of the cortex, where grade 1 it doesn't involve the cortex, grade 2 where there's thinning of the cortex, and grade 3 where it goes beyond the cortex. So you can see again, as mentioned by Prof. Suraya, over the posterior aspect of the tibia, we can see most probably there's a cortical breakage. So we classify as Kapanachi grade 3. So there's a systematic review of meta-analysis in 2013, published in 2013 in Open Ortopedik Journal by Teresa et al. In this study, it shows that in comparative, by doing a curettage to a wide excision, there's a 24% difference in recurrence rate when doing a wide excision, which is as low as 8%. And another article just published last year showing a similar result, which is a 20% difference of recurrence, comparing just by doing a curettage as compared to a resection. That's based on all this evidence from all these years. This guide us with our management and the reason why we did a wide local resection for this patient. So wide local resection is actually part of limb salvage surgery, where the principle of limb salvage surgery comprises of wide local resection, which is removing the part of the tumor with the cuff of normal tissue, skeletal reconstruction and soft tissue coverage, as what you guys have seen just now intraoperatively. And there are a few options of reconstruction, which are endoprosthesis or bone graft using an allograft or autograft or allograft, or we can combine using an implant with a graft, which is called the allograft prosthesis composite. So we chose endoprosthesis because the lesion in this patient is on a weight-bearing bone, which is the tibia. So by using endoprosthesis, patient was allowed to immediately weight bear after surgery. Thus, the patient can have a faster rehabilitation and early return to function, and the implant at this region is readily available with a comparatively faster surgery and with a good survival rate at 85% at 5 years. Okay. And they don't in this surgery they don't have donor site morbidity as compared to using an autograft, where patient may have pain over the donor site or surgical complications as well. And there's no risk of transmitted blood-borne diseases or graft rejection as compared to by using an allograft. Okay, so in conclusion, giant cell tumor appears like a sheep. It is classified as a benign bone tumor, and under the radiograph and microscope, it lacks the features of a malignant bone tumor. So it's easy to assume that a benign bone lesion can be treated conservatively. For example, benign tumors such as lipoma, up to the extent that we only see the patient when needed or when the patient have symptoms. However, clinically, giant cell tumor behave as aggressive as a wolf, which may destroy the bone and extend to the soft tissue with a high recurrence rate and even have the potential to metastasize. Therefore, even though it's a benign lesion, we treat it as a malignant bone tumor with wide resection and skeletal reconstruction, not because of its histology, but because of its aggressive behavior. And you know, if multiple surgeries preceding recurrence will be more detrimental to the patient. Therefore, remember this, the sheep look benign, but aggressive as a wolf. With that, I thank you.
Thank you, Dr. Afif. I believe our presenters today have provided us with concise and detailed information on GCT today. With that, I would like to thank Prof. Suraya, Dr. Shafiq, Dr. Afif, and also Dr. Tang in regards to today's presentation. Other than that, I would like to open the floor to any questions to our panelists as of this morning. If you have any questions, kindly move up to the microphone down the aisle and give a question. I believe our panelists is gladly to answer your burning questions.
Hi, Dr. Philip. Good morning. I'm Yusun from Final Year. I'm just curious that do we have any roles of medical therapy in giant cell tumor, namely Prolia or Denosumab?
Correct, we actually have. With that, may I pass to Dr. Shafiq regarding that question. Where's the, the mic?
Yeah, thank you for the question. Actually, yes, to answer the question, yes, Denosumab has a role in GCT, but provided that the grade will be a Kappa-92, meaning there's no bone destruction. And the idea of giving Denosumab is we're going to make the border more sclerotic for easier operation later on. Or in cases like if let's say to downgrade the management, if let's say previously the cortex too thin, there's a possibility of doing like more extensive surgical intervention like the one that we did just now. But after the Denosumab, after the lesion become more sclerotic, so we can downgrade the management, which is just extended curettage only, not doing the whole endoprosthesis part. Yeah. Yes, 3 also can. Yes.
Siapa punya soalan tadi? Okay. So I answer in general Denosumab. Rank ligand is a rank ligand inhibitor. In terms of treatment of GCT, FDA approved the usage of Denosumab ni only for 3 indications. Okay, number 1, you use it for unresectable tumor. In GCT, but unresectable and cause high morbidity. For example, in sacrum. So you have a GCT in the sacrum, which involve a neurovascular, a lot of sacral plexus, lumbar sacral plexus, and also sometimes already invade the retroperitoneal structure, right? So if you deem that tumor is unresectable, so you can consider using Denosumab to control the disease. You cannot treat the disease, but you can control it. Because by doing surgery, it will cause a lot of morbidity to the patient. That's number 1 indication. Number 2, Denosumab is used in a lung metastasis. Okay, GCT with lung metastasis, you can use Denosumab to control also the progression of the disease in the lung. Because sometimes small solitary lung metastasis, you can treat it by doing a metastasectomy, which means you remove the GCT. But if you have multiple GCT, not tumor cell, GCT in the lung, then you control with Denosumab. And the last indication, like what Dr. Shafiq mentioned, is when you have a very extensive bone lesion with destruction and also soft tissue involvement, you use Denosumab to control the progression before you do the surgery. Okay, to make it solidified. Because what Denosumab does is, when it involves the soft tissue too, they're soft. Kan? So when you want to do the resection, it's difficult for you to delineate the normal soft tissue and the disease soft tissue. So by using the Denosumab, you make the soft tissue harden. Somehow dia harden macam bone. Okay, so the bone part you will resect. The soft tissue that harden like a bone also you need to resect. So now you know the border between the normal soft tissue and the hardened soft tissue that is already comprised of the giant cell tumor. So 3 indication I mentioned before. Number 1, unresectable tumor. Number 2 is when you have a lung metastasis. And also number 3 is to facilitate your unblocked resection, you use Denosumab. Okay?
Thank you, Mr. Hafiz. And also thank you, Dr. Shafiq.
Oh, I nak tanya ni, what is the role of PET-CT in a surveillance to rule out any recurrence or metastasis?
Tak macam ni lah, you nak tanya siapa? Suraya ke nak tanya student?
Saya nak, postgraduate student. Postgraduate student.
Mana registrar? Tak tahu Tuhan kasih. Cian jawab.
Cheng or Jason?
Yeah, PET-CT scan, in my opinion, I think is one of the imaging which can be used to detect the distant metastasis. For example, like in this giant cell tumor, which commonly metastasize to lungs. So PET scan actually is one of the modalities to use to detect the metastasis to other places. However, I think the cheaper modalities, usually if we suspect lung metastasis, we can do the X-ray first. If we want to confirm further, then maybe we can do the further imaging, like PET scan.
Is his answer correct?
Well, PET-CT, Prof. PET-CT, yes, if let's say we suspect there is distant metastasis, there is a role we can do for systemic staging as well. So for surveillance, surveillance selalu tak, it's expensive and yeah, and it's susah nak dapat tarikh juga for the patients.
Memanglah expensive kan, but if it is indicated, you would request it. Anyways, unless you say that, oh, there's rarely, if you have done a great job, it's rarely metastasized. It will be like, if it recur, it will recur locally first, then only metastasize. So in this case,
I think PET-CT scan is a one-stop center kind of thing. You do it, everything it lights up if there's a malignant lesion. But the thing is, it is expensive. And for something like GCT, where the only place it's going to metastasize is in the lung, and even then we might not even treat it, and we can go through a chest X-ray, it is not cost-effective, let's put it that way. It's not cost-effective. There is no need for it because you can just do just as well with the local X-rays or imaging plus your chest imaging, which is sufficient. It rarely goes anywhere else. Yeah.
so I guess the answer is because the metastasis is very specific to the lung. It wouldn't go elsewhere that, which PET-CT we can detect everywhere. Okay, thank you. Nice presentation, thanks.
I know. I would like to say, what's happening after this? Are we done? There's like question and answer thing. But before that, I want to say thank you to my two MOs because I think, apart from Dr. Tang and Prof. but my MO hasn't slept for like 1 month. I have no idea how many times there. So it's really good, guys. On behalf of me and Mr. Hafiz and Ahmed, thank you for doing this great job. I like it. Okay, carry on.
Just to conclude the CPC as of today, that despite giant cell tumor is a benign lesion, but we have to keep in mind that this is an aggressive tumor, whereby limb salvage surgery, as explained by Dr. Afif here, needs to be evaluated as a definitive treatment. That is why a detailed history, clinical examination, blood investigations together with radiological imaging, and of course, histopathology, and also finally with a multidisciplinary team approach is very important for the best outcome for the patient. With that, I would like to thank all the presenters and so the chairperson, Prof. Hazla, in today's CPC. And finally, we will have a short quiz of 4 questions that we can put it up onto the screen here so that the students or even the doctors and so postgraduates can actually answer. Yeah, kindly scan the QR code.
Sementara you all login untuk ni kan, nak bagi tahu tak puas hati dengan kehadiran medical students. Banyak sangat lompong-lompong ni. Macam mana kita punya SPP persiap pula HEPA penolong dekan HEPA kata dah hebahkan dekat WhatsApp group. Prof Nur Azina pun dah hebahkan kepada all medical students. Please next time CPC you all must attend. This is great effort from the team, bukannya boleh dapat selalu ni. From tersohor punya professor, senior consultants bukan popliteal nerve tibial nerve dengan satu lagi apa tadi? Peroneal.
Okay, I believe the quiz is more or less completed. Okay, so there will be a total of 4 questions there. I believe the questions are quite informative regarding that. I think we have more or less completed with the quiz as of today. Once again, I would like to thank all the presenters, together with Chairperson, and kindly could you please give another round of applause to our presenters as of today, as is of the CPC that was done very good. Thank you.